Welcome, everybody. It's about noon, so we're going to get started so we can make sure we have time for questions and everything at the end. My name's Tara. I'm the program coordinator for the Central New Hampshire Community Opioid Response Program. And today, this is our third in our summer webinar series on harm reduction featuring Ryan Fowler. So just a little bit of housekeeping. Please mute your phone or computer.
How the presentation's going to go when you guys get.
You can submit any questions in the Q&A box or in the chat box, and I will read those off for Ryan at the end. And if there's any additional questions, my name and contact information are here. My program is a 3-year HRSA grant that was awarded to Katie and supported by Midstate, Spear, Park, and Lakes Region Mental Health Center. This is our mission and vision statement. Our mission, the Central New Hampshire Community Opioid Response Program, aims to ensure comprehensive, coordinated, and easily accessible prevention, treatment, and recovery services for those impacted by opioid use disorders in the Central New Hampshire region. And our vision for the future is that we will build a community to prevent, treat, and promote recovery from opioid use disorders. The program will create a local system that is free of barriers, easily accessible, and fully integrated at every point of contact to reduce opioid misuse and promote healthy lifestyles and promising futures. Here is a little bit about Ryan. Ryan is native of New Hampshire, and he is a person in sustained recovery, a certified recovery support worker. He's a former injection drug user and credits being alive in his clean bill of health to harm reduction evidence-based treatment. After working in addiction treatment and recovery for several years, Ryan began focusing on harm reduction, public health strategies, and overdose prevention efforts. Using both his negative lived experience and positive professional experience, he's grown in effectiveness and is passionate about helping other people who use drugs and to stay alive and find recovery. In January, Ryan began his current position as harm reduction coordinator for the HIV/HCV Resource Center, or H2RC, in Lebanon, New Hampshire. He operates the Claremont Exchange, which is a legal syringe service program in Claremont, and is looking to expand the program into Grafton and Sullivan counties. His goal for this project is to ensure that everyone in these counties has access to life-saving harm reduction services. And part of his role includes providing trainings to professionals in the community at large. And these trainings cover several topics related to harm reduction. For more information, his email and phone number is on here. I will send the slides out after this presentation. So you'll have all these links that we discuss here. These are also some links you'll have to some of Ryan's harm reduction videos that he has on YouTube. Those will be in the slides I send out. And we'll go back because that's actually the last slide. So Ryan, I'm going to stop sharing my screen and let you share.
Awesome. Thank you. Can you see that all right?
Yep.
Cool. All right. Thank you, Tara, and thank you everyone for being here today, taking time out of your busy life to come in and have a conversation about harm reduction. Part of this presentation was a little bit of biography about myself, and Tara, you did a great job of reading that bio. So we're going to spend the next hour talking about harm reduction. We are going to spend less time introducing myself because Tara already did that. But I will talk a little bit about the HIV/HCV Resource Center in Lebanon, New Hampshire, which is my employer. I am, as Tara had mentioned, running the Claremont Exchange and looking to expand harm reduction services into Sullivan County and Grafton County. And part of my strategy to implement that includes some sort of presence in the Plymouth region. fully funded, fully legal, fully ready to launch in all of Sullivan and Grafton County. I've spent the past few months kind of building some infrastructure in both the Plymouth region and the Littleton region, and also have been doing some outreach with some existing participants for our syringe services in the Lebanon region. Had a lot of success expanding in Claremont, educating people and empowering folks, and rolling out harm reduction services for really the first time in the Claremont region. The Claremont Exchange, it was actually founded by Dartmouth medical students as Project 439, and it was the first legal syringe services program in the state, but it was very small until I began this project in January. So we're going to really explore harm reduction as kind of a universal concept and how that relates to recovery, harm reduction being a pathway to recovery, but also a pathway of recovery for some, and looking at kind of some concepts of empowerment and self-efficacy within treatment and recovery programs. And hopefully by the end of this conversation, regardless of where you are, if you're just a community member, or if you work in prevention, intervention, treatment, or recovery, these harm reduction concepts are universal and dovetail really well into existing systems of prevention, treatment, and recovery. And we're going to start really broad on the harm reduction concepts too, so you'll see how that relates to really all aspects of life. We're going to spend some time talking about syringe services programs, also known as needle exchange programs. That's my primary full-time gig, is going out and meeting people through mobile outreach to collect used syringes and supply sterile supplies. We also supply a whole lot of naloxone and fentanyl test strips and a number of other services. So we'll kind of get into those in depth a little bit, give you some chances to ask some questions, and also maybe imagine what such a program would look like in Plymouth. I've rolled out or helped to roll out programs in Manchester and the Seacoast, which was very different than expanding a program in Claremont. There's some different strategies and ways to implement this, and we can kind of cover that a little bit. And then if we have time at the end of the syringe services stuff, I included some kind of like tips and strategies for engaging with people who use drugs, who are maybe in the pre-contemplation or contemplation phase, and really just kind of some stuff that I've learned from others, but also it really speaks to my lived experience as a former injection drug user and somebody who's in recovery from a substance use disorder. And so I'll kind of piece that into this. So basically the mission of the agency that I work with, the HIV/HCV Resource Center in Lebanon, is to support and empower those whose lives are affected by HIV and hepatitis C, to live fully and with dignity, and to stop the spread of these diseases through education, information, and understanding. We are a small agency of 5 staff members with some volunteers. It was actually originally founded about 30 years ago as, it was at one point known as Acorn, and it was really started by people who were either dying from AIDS-related illnesses or had someone who they loved who was dying of AIDS-related illnesses. And from there, it's kind of expanded, and medical science has done a wonderful job of addressing HIV and really kind of reeling in that crisis. And syringe services programs are a big part of the effort to reduce the spread of HIV and hepatitis C. And so in 2006, H2RC, when I say H2RC, I'm referring to the Resource Center in Lebanon, opened our first syringe services program in Vermont in 2006. So this agency has been providing syringe services in Vermont since 2006. And all of our services are free of charge to residents of Windsor and Orange County, Vermont, and Grafton County, Sullivan County, and Cowas County in New Hampshire. And in January, I started my position as the harm reduction coordinator for H2RC. I was handed a program that was run by Dartmouth medical students that was housed in Valley Regional Hospital for 3 hours, 1 day a week, and it was incredibly underutilized. And from there, we started with mobile outreach, and then COVID hit, and the hospital and H2RC agreed that it wasn't a good fit to be having people come into the hospital for a syringe exchange. So we went to fully mobile operations, and when that happened, a couple of our participants really took ownership of it and spread the program tremendously through peer-to-peer connection. And because of that, we saw some exponential growth in those first few months, and we've kind of stabled off quite a bit. And it's been wildly successful. I'm really proud of the participants of the program. And really, even though I've attended a lot of meetings, I've really had no provider referrals. The expansion of this program was really all in the hands of people who actively inject drugs, person to person, friend to friend. It's amazing how much naloxone gets out and gets used and then gets told to me that it got used, and we can have conversations about education. And it's really been a privilege to be out here in Claremont. I'm coming from the Seacoast, born and raised in Hampton for the most part, in Seacoast, and I've worked primarily in Manchester and Nashua around the safe stations and the doorways. And I've also, as a volunteer, helped to implement some syringe service programs throughout the state. And it's just very different out here. I've never lived in really rural New Hampshire, and I'm really excited to continue working with my friends up in Littleton at the North Country Health Consortium, and also my friends in Plymouth, and really get to know the folks at the whole village center there. I remember I went one time when I was really impressed, and it was just before COVID, and I wanted to come back up when it was nice out. And so hopefully I can get up into your region soon in some fashion. So what is harm reduction? We hear it quite a bit. It's been in the news more and more as we look at the overdose crisis and the addiction crisis and everything that's kind of piled upon that. And oftentimes harm reduction elicits an image of a guy like Dave Purchase, who you see here, providing sterile syringes and collecting used syringes from folks in the peak of the HIV epidemic. That's him in Tacoma, Washington, illegally providing this service. And he said, you know, if you're going to arrest me for giving out condoms and syringes, then arrest me. And it was because of some grassroots movements and individuals like Dave Purchase and the folks that came before me doing this work that we were able to really flatten the curve for HIV and really mitigate a lot of suffering for people who are marginalized, people who use drugs, people living with HIV or Hep C, sex workers. But really, harm reduction is a universal concept. We're using harm reduction every day in our life. You know, I really don't want my friends to jump out of the plane, but if they do, I want them to wear a parachute. A parachute's harm reduction. And, you know, when I go out on the boat, I wear sunscreen, or, you know, when the time is right, I wear a condom. My car has airbags. In our society, if we think about the drug alcohol, we have these supervised consumption sites where people can go and buy safely regulated alcohol, consume it with supervision, employ harm reduction strategies, and hopefully get home safe. They're called bars. You know, we use harm reduction in a lot of different ways, but really it's a set of practical strategies and ideas aimed at reducing the negative consequences associated with risky behaviors. So anything human can both help and harm. And any behavior really has risk associated with it, whether that's breathing the air around us or injecting risks associated with human behavior. And with harm reduction, you can reduce those risks. And as we get more specific today, and we talk about specifically drug use, it's a set of evidence-based practical strategies and ideas aimed at reducing the negative consequences associated with drug use. So drug use is an interesting human behavior. There's actually no recorded human history without drug use. It seems that people have always used drugs, and so I highly doubt that we will see that drug-free community that we pay so much money for. Drug use is just something that happens, and we really only know prohibition. We really only know 100+ years of a criminal response, of treating a health issue like a criminal issue, and taking a healthcare condition and handing it to law enforcement. And we really only know punishment and contingencies and ultimatums that are attached to drug use. And we say to somebody, well, if you use drugs, then you have a disorder and we need to either criminalize you or medicalize you. But really, drug use is really ubiquitous in the human species. So if there's no human history without drug use, then there's no human history without drug users. And so when we get into harm reduction with a capital H and a capital R, which we won't spend too much time on, but harm reduction is also a movement for personal freedom and justice, built on the belief in and respect for the rights of people who use drugs. So if we think about a system that criminalizes people who use drugs, then they have their personal freedom and their rights taken away from them. And harm reduction in this sense is really born out of something happening. And when you see harm reduction throughout history, harm reduction is born out of things happening, whether that's prohibition, HIV, hepatitis C, the overdose crisis, and now we're in the times of COVID-19, and we're seeing harm reduction programs being deemed essential services because harm reduction is proven to be very effective. And before I get too preachy and high up on my soapbox, I just want to make some disclaimers that harm reduction is not about whatever happens, happens. This is not saying go do whatever you want and, no, this is not about saying anything goes. It's about controlling an uncontrolled situation. It's about having a public health framework and reeling in some chaos that's happening in our communities. And it's not just about meeting people where they're at, but it's taking them with us. It's meeting them where they're at and supporting them to change their behavior. It's meeting them where they're at and showing them dignity and respect and empowering them to make better choices. Harm reduction is also not about helping a person who has stopped using drugs to start using again. And it's not about proliferating or promoting or condoning or endorsing or encouraging drug use. No one has ever showed up to a needle exchange and said, I'd like to inject for the first time today. This is about creating a pathway to recovery and a pathway of recovery for people who are marginalized, and really, it's pretty heavy for folks who are at the harm reduction stage, and it's really it's heavy content we're going to get into, but we're really going to focus on the services, and we're not going to focus on the capital H, capital R harm reduction too much. So this is not a conversation about drug policy or legalization or decriminalization, but we would really miss the mark if we didn't address the role of the drug war in the overdose crisis that we're seeing right now. And so harm reduction, as we get a little bit more specific, so I was just reading the chat, sorry. So harm reduction, as we get a little bit more specific, and Tara, if there is a question of some sort, feel free to interrupt me. I don't need to be the only person talking for this hour. I'd love some kind of chime in from the audience. But so we started really broad, and we're going to get more and more specific. And as the work that I know a lot of you do in your day-to-day life, professionally or personally, it's a framework for working with people who use drugs or for people who once used drugs. And I just want to highlight that harm reduction is a spectrum of strategies that includes abstinence. So for many people, harm reduction means that they don't use drugs anymore. For other people, harm reduction means they use a new syringe every time and carry naloxone. It's different person to person, but it's really about striving for any positive change, any steps in the right direction. And, just because I'm 5.5 years into recovery, that doesn't mean I can't improve. I'm always trying to improve by 1% wherever I can to experience growth. And so I continue to use harm reduction where I eat, how I eat, how much I eat, how much I exercise, how much I sit on my butt, how much I do yoga, dieting and all that stuff in my life. I just have a harm reduction lens for everything. And it's pretty effective. I like it a lot. But harm reduction as it relates to working with people who use drugs, it's person driven or client centered. It's not about coercion or, ultimatums. It's about supporting people and not punishing them. And I've seen a lot of innovations in the addiction treatment world, especially since I was the service population, 5 to 10 years ago, when I was kind of in and out of treatment programs. I saw a lot of things that weren't helpful, and it's been cool to use that experience to kind of highlight it and show that, if a substance use disorder or an addiction is, characterized by continuing to use drugs despite negative consequences, why do we offer negative consequences? Like, why is it that all our society can offer people who use drugs is negative consequences and coercion and ultimatums and contingencies? It's a little backwards, and really looking at the most promising research on, supporting people with use disorders. It's about positive reinforcement and contingency management, and really having a strengths-based, person-centered approach, and allowing people to define their own goals, decide what they want to work on, and allow them to go from there. And it really fits nicely into existing treatment systems for sure. And harm reduction is a framework for understanding drugs as well. We view through the lens of science and not morality or ideology or fixed ideas. Harm reduction always looks for the most breaking research and evidence. And, we can call addiction a disease or a substance use disorder, a health condition or a disorder, whatever you call it. We treat it like a crime. So if we're treating it like a crime, we're really not there yet. We're truly missing the mark if we're handing this health issue off to law enforcement every step of the way, And so harm reduction acknowledges that some drugs are safer than others. And so if I'm working with somebody who, wants to stop injecting their drugs, or they want to go from the fentanyl that's out there to cannabis, let's celebrate that. Like, let's reinforce that positive step in the right direction, rather than saying, you're not sober, you're not in recovery, like maybe you need to experience some more pain or hit a new bottom or earn your seat, or no, that's just like, that's not healthcare. That's not helping people, it's harming people. And harm reduction really looks at the context of use as well, beyond the drug. It's really important to look at the work of Dr. Norman Zinberg and his work looking at the drug set and setting framework. So of course, it's important to understand what the drug is and what folks are using, how they're using it, what it's cut with, but also it's important to look at the set, and that's the unique person coming to the table, their physiology, their psychology, their emotional state, their cultural identity, their sense of belonging, and their expectations or motivations for using the drug. And so we could have a group of people who all use the same drug, and if we ask them, what are the benefits to your substance use? What are the reasons you're using it? You may hear somebody say, well, it started with lower back pain, or you might hear someone say, well, I used to party, or you might hear someone say, it makes the voices in my head stop. It's kind of three different recovery modalities. If you think about it, you're kind of addressing different things based on the person's expectation or motivation for using, but we largely have, and it's a lot better, but largely treatment is kind of cookie cutter. You all get the same workbook. You're all here today, all 15 of you are doing the same exercise, but people are very, very different. And the more that you seek to understand these folks, the more you see that, there's a lot of ways to reduce harm and help people. And that goes to looking at not just the individual, but the setting that they're in, the stressors in their life, the socioeconomic stuff, the person's supports or lack thereof, with who a person uses with, and the social or cultural attitudes towards the drug and its users. And so there's a lot of stigma with meth right now, and I'm working on that in my own life. It's been really complicated to work with some folks who are using the stimulants that are out there. But really, it's there's a lot of stigma, and when we talk about stigma, it's really just a nice way to talk about discrimination. We're really just offering discrimination throughout healthcare and throughout systems that, there's really no system that isn't complicit to this. And, I came into recovery and I had a really great time with recovery. I enjoyed treatment. I enjoyed sober living. I enjoyed outpatient. I got a job. I had a family that could support me and house me for several years. And they told me that was recovery capital, but, largely it was privilege. I'm a straight white male, middle class from New Hampshire. And I didn't think I ever faced discrimination except for my time as a drug user and an injection drug user, and being profiled and criminalized, followed through stores, kicked out of my family's home, services withheld from me, treated like crap in healthcare. Like, that's discrimination. Like, stigma is the feeling, but we really need to name names and name actors in this stuff, because it's hard to break through. Like, this is the world that we live in, and it's hard to break through. And so as we get into harm reduction a little bit more specifically, the goal is to essentially improve the health and well-being of individuals and the people around them. And that is a spectrum of strategies, but it's also the goal of harm reduction to highlight the roles of discrimination due to poverty, racism, classism, sexism, social isolation, trauma, and other inequalities and drug-related harm. And so it's really important to have these conversations with people because classism or racism or homophobia may be a part of their drug use that they've not explored yet. And it's really comes back to, you know, what are the motivations or reasons that you're using this drug? And you may find some really uncomfortable content around trauma or social isolation, but harm reduction is really a holistic approach to addressing these issues. And you know, once I found the harm reduction community and started to attend these conferences and learn more, I kind of found the people I wanted to meet in the recovery community. Like, I love the 12 steps, and the 12 steps, you know, I'm all the proof and evidence I need for the 12 steps, and like praise to God and Jesus and the church I found and the pathway of recovery for me. But it's just harm reduction is very genuine and raw, and there's like a lot less you know, a lot less masks. And it's really because we can have open and honest conversations, and open and honest conversations are the foundation of harm reduction, along with education and empowerment, and including folks in this movement. Harm reduction kind of waves the banner of nothing about us without us. And so as I look at strategizing, rolling out some harm reduction programs in regions I'm not from, I would like drug users to be involved, or people in recovery to be involved, and really kind of see what makes sense for potentially the Plymouth region or the Littleton region, these counties that I'm able to cover with the Strength Services program. And really what I experienced in recovery and treatment was really the traditional prescriptive, very ultimate, absolute approach of your goal is to be abstinent and manage symptoms. This is the program. If you leave, you're done. But as I got into recovery coaching and the work of William White, we see recovery-oriented systems where treatment systems and the community at large is talking about recovery and asking, what do you need? Or what do you want? You know, what someone wants really is important, but we have this approach to healthcare, but especially with substance use disorders, that, you know, they can't get what they want. You know, I know what they need, and they need to understand what it is they need, but they're the expert in their story and their experience, and they're the master of their destiny. And if we look at empowerment modalities and helping people to be the power and have that connection, we can save a lot of people and have a lot better retention. And we can ask people, you know, what do you want your future to look like? You know, is it your goal to be abstinent? And if it's not their goal to be abstinent, how do we work with those folks? What do you want to work on today? And if you leave, we want you to come back anytime you're ready. You know, I didn't hear that. And when I started working in addiction treatment, I was, if you leave, you're done. You know, I was very cold and callous to some folks. And I know now that compassion and dignity and respect are what win people over, because people are on a natural pathway towards recovery. They just need that little boost, that little bit of recovery capital, that little bit of empowerment. Because once they find that dignity and respect, they learn that they do have autonomy and agency, and they can define their own goals and live a self-directed life and reach their full potential. And they'll make better choices. It's kind of a natural thing. If given the choice, people will make better decisions, but they need to be educated. And so as we get a little bit deeper into substance use, our society kind of forgets that drug use is on a continuum. We're all, when I say drugs, you can lump alcohol into this. And I find that for some folks who are new to these concepts or who have not used and sold drugs the way I have, alcohol is a good kind of lens to look at this through, as we kind of talk about things like moderation and harm reduction. So essentially, we're all born abstinent of drug-taking behavior. You know, an addiction is the continuance of a behavior despite negative consequences. And I'm very much aware of the rise in neonatal abstinence syndrome in New Hampshire especially, but we're all born abstinent of drug-taking behavior. The large majority of human beings in our society will experiment with drugs at some point in their life, whether that's caffeine, nicotine, alcohol, cannabis, cocaine, psychedelics, you name it. the large majority of human beings will experiment with drugs at one point in their life, whether legal or illegal. And most people, end there. They don't really go past experimentation. Their life is fulfilling. They have really no need to self-medicate. But a lot of people do occasionally or socially use or drink alcohol, and most end up practicing moderation. The majority of people do not have a substance use disorder. Although I will say that I was looking at some data on people who are living in homelessness, like houseless folks, and there's like over 500,000 homeless folks in America right now. But as far as housed adults, 16% have a substance use disorder. I thought that was really high for housed adults. It was 16%. But that's still the minority of people who use drugs. Most will moderate. Most people kind of enter this stage around 25 or 30 where their hormones change, their priorities change, their career gets in family kind of come into play, and drugs just kind of fall out of the equation. And we really fail to talk about, self-initiated moderation, or like that native recovery, that natural approach to recovery that happens. But we kind of paint this picture that everybody goes to treatment, everybody goes to rehab like I did. I went 4 different times, some of my friends have gone dozens of times. We kind of have this idea that people are either abstinent or they're in like heavy chaotic use. But as we go to the spectrum, less and less people are kind of on that end. But for those that are on the spectrum, I don't mean to say like that, who do have a substance use disorder, who do meet that diagnostic criteria, chronic health conditions fall on a spectrum. There's, less managed or more managed, there are less controlled and more well controlled. And if we think about any health condition, this is a model that makes a lot of sense. I like asthma as an example because not only do I have it, but it's partially hereditary to a point, but not truly. It's environmental. It's controlled with medication. It can go into remission, but some have to be on medication for life. I am dependent on my asthma inhalers, but I'm not addicted to them because I'm provided the medication I need for my health condition. And I take incremental change steps. I exercise more, I get more fresh air, I drink less milk. These are kind of things that work for me. And we think about a substance use disorder, we really kind of don't have conversations about the middle of the road folks, the moderation folks, the harm reduction folks. And we elevate stories of abstinence, and we hold recovery-friendly events where all the recovery advocates are at abstinence-based 12-step recovery. And we kind of talk about it's either, chaotic or abstinent. But if you ask a cross-section of people entering into addiction treatment, mostly you'll find that their goal long-term is to be moderating and to find moderation and to find some sort of strategy that makes sense for them. But we define their goal as abstinent. And then we look at treatment outcomes and we say, well, this program has a 10% success rate. Why are we paying millions, actually billions of dollars for this treatment system if largely programs have a 10 or 15% success rate? Because that success is deemed as abstinence. And any human behavior serves a purpose. And if we look at, drug taking as serving a purpose, we can see in our current society with the recession and the times of physical distancing, why substance use is on the rise. And the more that I do harm reduction work, I see why people are using drugs. And a lot of my friends are on the moderation platform of recovery. A lot of them are on the abstinence platform. It really makes no sense. As long as we continue to improve, as long as we're always working to grow and not grow stagnant or regress. But if people do relapse or kind of fall back towards chaotic use, harm reduction is that safety net. And harm reduction is a really great way to keep people engaged in services and treatment and keep them alive too, because people die of this thing. About 70,000 people in America a year die of a drug overdose, and there's a lot more suffering involved in other areas related to this. And with harm reduction, all drug-related death and disease is preventable. This is about preventing countless billions of dollars, countless cases of disease and overdose, and really keeping people alive to find recovery, because dead people don't enter recovery. And for a lot of people who I grew up with. Harm reduction is what I have right now to stay connected with them and also to keep them alive so that they find recovery that makes sense for them. So I have a question here from Mikey G. Would you say that periods of problematic use are largely episodic and tied to age? I mean, it depends on the individual. I'm working with a guy at the exchange right now in Claremont who didn't use really anything but cannabis until his mid-30s, and it was because of a really horrible surgery that went terribly wrong, and he spent the past 5 years diving deep into a fentanyl addiction because he couldn't get adequate pain medication. He really didn't fit the bill 5 years ago, but he sporadically kind of dived into chaotic use. And so I think it really doesn't discriminate, and there's a lot of factors that play into chaotic or heavy use, but it's about the individual to answer that question, you know. And for some people, you know, so I just kind of want to kind of slide this in a little bit, kind of based on time, because I could talk about this stuff for the whole hour. But we're talking about drugs a lot. We're talking about harm reduction a lot, but we're here for, you know, recovery programs and treatment programs, and to find the people that we want to help and to have them find meaningful recovery that makes sense for them. And so I like to use SAMHSA's working definition of recovery, which is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. So I like that because I can do that every day, even though I've been in recovery for 5.5 years. I like that because with that framework, I can lump my syringe service program participants into this tent of recovery, and we can really get more people to identify as being in recovery. And if we use this to explain recovery to folks who have no lived experience with drugs or alcohol, they can see that this is relevant to their life, and they can find more of an empathy and connection to this. But so, of course, improve health and wellness, providing people with education and sterile supplies and access to healthcare, live a self-directed life. Of course, doesn't everybody want that in America? Like, we really need to be looking at the individual, but also the understanding that full potential is limitless for many, but for some, their full potential includes taking drugs that are sometimes deemed illegal. And that's kind of a heavy conversation to have. And so when I'm talking to folks who are at the harm reduction stage, I'm asking, and I have a couple that are like really on the fence. I've had a bunch that are now in recovery, and I don't hear from them anymore. The majority of my first clients are no longer injecting, and I don't hear from them, which is tough because I want to call them, but I'm kind of the needle guy, so I kind of have to have faith in like the Center for Recovery Resources and Turning Point and some other like MAT folks that we work with. But I ask folks, you know, like, is it your goal to be abstinent? Have you ever tried medication? What motivates you to change? Have you ever tried setting personal limits? So moderation management is sometimes about like journaling or keeping a log of what you use, how you use it, how much time you spent, how much money you spend, things like this, and setting limits around that. And that down here at the bottom left, that here to help guide, view and substance use, is a really great free printout available from the University of British Columbia. Really cool, awesome stuff in there for folks who you know, are kind of motivated for self. And I recently had a presentation with Midstate in Plymouth talking about stimulant use disorders and kind of these the illusion of control that comes with especially meth use. And so if you have the individual steering the ship and in control of their treatment program, they have a lot better retention. And so moderation management is a really great conversation to have, but just remember to use your motivational interviewing techniques and be asking them open-ended questions, you know, questions that don't answer with a yes or a no, and offer them affirmations. You know, I find that emotions are always valid and people want to be affirmed and be heard. And so then I offer reflective listening and summarizing in the conversation so that they know how they're being heard and that we're on the same page. And sometimes folks aren't aware of how they're presenting, and especially the folks that we're trying to help, they're not necessarily connecting their consequences and the negative in their life to their behavior, because that behavior serves a purpose. And so once they understand how they're being heard and they're understanding, you know, their motivation to engage in a behavior like drug use, the consequences become a lot more clear. And so motivational interviewing is a really great tool to move people through ambivalence and develop discrepancy and kind of move people towards a more natural form of recovery. And so harm reduction strategy is to reduce mortality by providing access to cost-free naloxone. And so something that we could do in the Plymouth region or really anywhere in Sullivan or Grafton County is update naloxone training and naloxone access and do some outreach and follow-up for overdoses, giving folks access to evidence-based treatment options and not just saying go to whatever one you can get to. Housing First is a harm reduction strategy that is basically offering at-risk, kind of complicated folks housing without contingency so that they're sleeping, they're accounted for, they have a safe place to be, and the rest of the services they're engaged with work a lot better when they're housed. So we need to be looking at housing first with the incoming wave of evictions and foreclosures, with the federal moratorium on evictions that ended July 25th. So we're going to see a lot more houseless folks, and there's 500,000 houseless folks and 1.5 million empty homes. So we could give every houseless person 3 houses. So look at housing first. Criminal justice reform and drug policy reform, I talked about that quite a bit. On-site drug checking. So at the Claremont Exchange, we offer fentanyl test strips, and I'm also working with some folks in Littleton on offering people who are using opiates or even really any drug fentanyl test strips, because right now any pill or powder could contain fentanyl, and so stimulant users and other drug users that are not opioids are at risk for fentanyl overdose. So we give fentanyl test strips, and I'm also working on professionally rolling out reagent test kits for on-site analysis of the drug supply so that people can make more informed decisions. Healthcare is harm reduction. Supervised use is a concept you're seeing in the news more and more, but when I say supervised use in New Hampshire, I'm talking about creating a culture of people who don't use alone and carry naloxone. And then of course, syringe services programs. We're probably gonna wrap up here and give a chance for questions if there folks want to kind of chime in a bit. So the goal of harm reduction is to prevent disease, and that is why recently Surgeon General Jerome Adams came out and for the first time gave a full endorsement from the federal government of syringe service programs as a public health response in a way to mitigate disease and death. And so we're seeing a rise of HIV, especially in New Hampshire and Vermont along the kind of 91 corridor. There's some money that's come to the state to address the rise in HIV and potential for an HIV outbreak, because if we look at the HIV outbreak in Indiana or in Lawrence and Lowell, there's the same epidemiological markers around those HIV outbreaks that are present here in New Hampshire. It's a fentanyl crisis, no access to sterile syringes, homelessness crisis, and the clearing out of homeless encampments and displacing people. So it's really, New Hampshire's at high risk for HIV. And there is treatment available, and folks can engage with HIV medication and be undetectable. Their viral load is so low that it's become undetectable, and that becomes untransmittable. And so HIV cannot be cured yet, but folks can be U equals U. Undetectable equals untransmittable. And hepatitis C, in April, I believe the CDC released new guidance for hepatitis C because based on the continued surveillance of hepatitis C and the lack thereof, it's estimated that 1% of all adults in America are carrying hepatitis C. 2.3 million is the estimate, but a small percentage of that is actually logged. But there's been very, very little surveillance of this until recently with the opioid crisis that's been going on and the rise of injection drug use. And the good news is that with the Claremont Exchange, we have partnered with Dartmouth Hitchcock to basically develop a one-page referral and release of information so that our participants with the syringe service program can fill out this one-page release, and we fax that directly to Dartmouth Infectious Disease. The person takes one trip to Dartmouth to have their viral load count and fibrosis liver scanned for their hepatitis C, and their entire medication and follow-up for their treatment for hep C is through telemedicine. And the new medications are so cheap that Medicaid will pay for it without any abstinence. My participants at the SSP can continue to use the entire time they're receiving treatment for hepatitis for 8 to 12 weeks, because the cost of hepatitis long-term with cancer and the late-stage hep C is in the millions per person, and the medications are much more cheap. So we're really trying to push every person at least once to be tested for hepatitis C, to know your status. Big for baby boomers and folks who are receiving medical care prior to screening for hepatitis C in blood products. And also we see a lot of infections and endocarditis from injection drug use, and syringe service programs are a way to reduce those issues. And also, so I'm gonna get to questions at the end, I guess, because we're really short on time. So syringe service programs also, they protect law enforcement and other personnel from needle stick injuries. They promote public health by taking used syringes off the streets. Over 30 years of research show that SSPs do not increase crime or drug use, but actually reduce it. It proves that they're cost effective, decreases new disease, and they act as an access point to substance use treatment. And people who inject drugs are 5 times more likely to access treatment when engaged with an SSP, and 3 times more likely to quit injecting. And I see that all the time. I'm starting to track my referrals more thoroughly. It's really amazing what engaging with a program like this does for an individual, because they get criminalization and discrimination everywhere else. And there's opportunities for multiple interventions and access to care. So the point is kind of what I tell people. The syringe is really why you're there, but also it's crisis intervention, wound care, disease testing, which we can provide on site. I am trained to provide on-site finger prick blood tests for HIV and Hep C, and that is something that could happen in Plymouth. COVID makes it hard, but I do have face shields and all that jazz. So we give out a lot of naloxone, so it's a way to reduce overdose deaths, because the person who's most likely to reverse an overdose with naloxone is a person who uses drugs. So we want to get the Narcan in the hands of people who are going to use it, and I'm tracking some really wild overdose reversal numbers that might be higher than EMS. I would really like to get to a point where I can prove that. I'm working on it with data, but so far so good in Claremont, 7, almost 8 months in. A lot of people are connected to services, and makes a lot of sense to have a CRSW doing this work for sure. And really an SSP could look a number of different ways. It could be a fixed site, like a brick and mortar building. It could be a temporary structure, like a tent. It could be mobile. Like right now, the whole Claremont Exchange is my Honda Civic. I go and meet people where they're at, outside their home, at Walmart, wherever. I do some home delivery. Before I was on this call, I delivered some supplies and did a 1-for-1 exchange. I gave her 200 syringes. She gave me 200 in her bucket. We chatted outside for a minute. Looks a lot healthier for sure. I was really happy this morning to see her. She's been around for a couple months now. Street outreach is something that could happen really anywhere, and mail orders. So sometimes folks will get stuff through the mail through like nextdistro.org. The CDC supports this. This is kind of the elevator pitch for SSPs. These are all endorsements of syringe service programs. And so for folks who are on the fence or don't think it's a good idea, I can point to 30+ years of empirical research and evidence, or I can point to these agencies who have offered endorsements of syringe service programs. We do also provide folks with sterile supplies. So we give them sterile water, cotton filters, cookers, or where they mix their injection supplies. And we give them alcohol pads, and we educate them that anything here you see could be a vector for disease, and hepatitis C and HIV can live outside the body. And so a lot of folks end up contracting hepatitis C and HIV from sharing water or cotton filters or cookers. And so we give each of our participants their own little sterile sealed bag of injection equipment. Some like it, most really like it, some aren't really hip to it yet, but they're all at kind of different stages. And safer disposal is a big part of an SSP, but for most of New Hampshire, the best thing that they can do is to put their syringes into a detergent bottle that's puncture-proof, labeled "do not recycle," duct tape it, and put it in the trash. But we would like to have a point in time where we're working with hospitals and transfer stations and a syringe service program to make sure that we're not jeopardizing our municipal workers, our frontline personnel. And evidence shows that when there's a legal SSP in a community and individuals know that syringes are not criminalized, as they are not in New Hampshire. New Hampshire has some of the best syringe service laws in the country. And once they know that they're not criminalized, it protects law enforcement because there's less evasion. Because you can talk to law enforcement, and oftentimes their number one fear is being shot in the line of duty, right on that top of the list is needle stick injury. Like, you know, they work with a lot of folks who use drugs, and it's really, once you kind of get into this, law enforcement, in my experience, and really any area that I've helped roll out SSPs has really been on board. And as far as rolling this out in a community, you really don't need to go and have a public blessing from everybody. It's really about, you know, the police chief, the fire chief, the public health folks, and the recovery community. If you do this right, folks don't know this will exist. At the most, they see a group with backpacks handing out sandwiches and water, and we have Narcan. And mostly these programs in rural communities like New Hampshire are basically secondary distribution. And so for a lot of my folks, rather than me seeing 10 people to give them each 100 syringes, I give them one person 1,000 syringes, and they go about their business and secondary distribute and also collect. And you know, this is also an example of where a lot of New Hampshire is at with harm reduction, and that's, you know, telling folks to bleach their stuff, because many areas of New Hampshire do not have access to syringes at all. So sharing is common, and so is bleaching these syringes to get rid of HIV and Hep C. So the question about law enforcement generally supporting this, yeah, and that's another point of education for sure. So I can definitely answer any more questions. Polly has a question here. How can we get social or moderate users, everyday people, to recognize they have more in common with drug users and that they actually are using harm reduction practices? I don't know. It's a journey for everyone. You know, I taught a really interesting HIV update yesterday, and so there's some people in, you know, 12-step recovery that are having a really hard time with it, and it was kind of like, we're not talking about you. You know, like, you're in recovery, great, that works for you, great, do that. But it's like, everyone's very different. And you know, my first year of recovery, I didn't really understand harm reduction the way that I do today. I spoke negatively about people who utilize MAT, and then I became educated, and I learned a lot more. And trigger warning, the next image is needles, reuse needles. So this is a view of a new needle point, brand new, used once, used twice, and used 6 times. And some research in New Hampshire that happened prior to Senate Bill 234 passing in 2017, which legalized syringe services. There was some study done in Stratford County that found that people were reusing 20 or 30 times, and that conditions for some of them were pretty comparable to third world for injection drug users, how they're treated by law enforcement and healthcare, and how they have access to nothing. So we've come a long way for that, but this is the point. Like, this is, you know, I have people in the program that inject every day and who have 0 track marks. They can wear short sleeves because they use a new syringe every time. They use an alcohol pad before they inject, and they make better decisions. And at the end of the day, harm reduction saves lives. And it's really important now more than ever in the times of COVID and the overdose crisis and all these awful crises. So I'm happy to kind of answer some questions. And this slide deck's gonna be available to you, just some stuff for talking to people about drug use and understanding the role of autonomy and agency in people, and, you know, empowering them to make better decisions, and not punishing honesty. You know, honor those open and honest conversations and allow them to be heard, and you know, master that motivational interviewing stuff. It's a really great technique. Meet them where they're at, but empower them, show them dignity and respect. So I can leave here and go meet a participant at the SSP and show them a lot of disrespect and you know, disempower them. That's not harm reduction. That's just me giving them needles. But I take the time and I hear them out, and I don't evangelize them. I ask them those open-ended questions, you know, hey, is there anything I can help you with as far as referrals or resources? Or, hey, do you have any questions? Or, hey, you look great today. Are you drinking more water? Because I know that we identified that a goal for you might be to drink more water. And it's really a privilege to get to see people in a lot of suffering and pain, and in a short period of time find recovery that makes sense for them. And you know, I'm still kind of wrapping my head around your question, Polly, about you know, how do we get everyday folks to recognize they have more in common with drug users or people with substance use disorder. And I like the alcohol or nicotine example, or, you know, cell phone addiction, and the role of dopamine in cell phone addiction is kind of helpful. But talking about bars like supervised consumption sites is kind of like a, oh, okay, I get that. So let's see. My brother was a drug. So Heidi, her brother was a drug user in Oregon, and their no harm programs helped him when he was homeless. He's clean now and doing great. Married, bought a home. These programs work, and thank you for your caring. Thank you so much, Heidi. That's great. And you know, I love recovery, and I love where I am today. I'm peaking in life professionally and personally. But harm reduction kept me alive for at least 5 years. You know, I was a 20-year-old naive drug user when I started to inject, and I met two people in it was probably 2009 or 2010 that kind of looked at me and my behavior and said, hey, like, you know, two of them separately, they didn't know one another. They educated me and provided me with sterile syringes. One was from Vermont and one was from Massachusetts, where syringe services were legal. And I didn't get it. I thought it was cool because I was getting free new needles. But I don't have Hep C. I don't have HIV. I never got endocarditis. I did get a bacterial infection in my blood, and I have a minor heart murmur, but it's fine. You know, harm reduction kept me alive. I was saved by naloxone 3 separate times. My opioid overdose was reversed by naloxone. And I come from a social circle of people who are here because of naloxone and here because of harm reduction. So harm reduction keeps my friends and family alive, but it's also why a lot of my friends and family are here today. And I think that as we, you know, integrate harm reduction and the evidence-based model into these systems that we all work, live, and play in, you know, we'll see, you know, the truth will prevail and science will win. It's just right now we really need to speak truth to power and acknowledge that, like, prohibition doesn't work. Prohibition has only given us the overdose crisis and everything, you know, prison industrial complex, the whole thing. Prohibition is a vehicle of oppression and makes no sense. And we really need to move past a prohibition mindset. And so Mikey G again, one of my favorite people in the world, Michael Gallipo, embracing a human rights framework for the full range of drug use so as we pathologize drug use broadly, it's extremely difficult for people with non-problematic use to identify this way. Same with discrimination and legal consequences, both significant barriers in identification, for sure. And the legal consequences, you know, I've been arrested over a dozen times with felony drugs multiple times. I'm not a felon. I've had multiple alternative sentencing programs. White male privilege, you know, when I get pulled over, I kind of chuckle. Treatment systems are really designed for people like me. Legal system is designed for people like me. So we really need to address, you know, these issues of racism and classism in our society. And harm reduction is just a way to insulate people from the structural violence and systemic inequities of the drug war and of, you know, a kind of prohibition mindset. And, you know, really, you know, this is just some more stuff on engagement for folks and autonomy and agency and consent. We really need to open up to consent and bring consent into all areas of our culture and ask, you know, do you consent to these services? And I would encourage you to explore your own issues about drug use and celebrate any progress with people and practice self-care. This is really heavy content. And this is my email address and phone number. And at this time, it looks like it's 12:58. I know that Scott has to take off. And so if you do have to take off, I totally get it, but I'm happy to stay on and answer questions. So thank y'all for taking time to come here and talk about harm reduction. I'm hoping to have some of you reach out to talk about how we can bring some sort of harm reduction to the Plymouth region. Good things to come, and it's a pretty light lift, and it could happen sooner than you think. So let's continue these conversations. And once again, I thank you, Tara, and the whole team at Katie, Midstate. I'm gonna forget some of them. All you guys are wonderful, and I look forward to working together. So thank you so much.
Definitely. Thank you so much, Ryan. That was wonderful. I will be sending out the slides afterwards, as well as a link to the recording of this webinar for our new YouTube channel that we just started, which also has our prior to talks on MAT recovery and drug court and restorative justice. So when you get that link, you can watch all three if you like. And if we have no other questions, I think we can wrap it up there. Thank you again, Ryan. Wonderful, as always, and we'll talk soon. Thank you, everybody, for attending. Have a great afternoon.